Another finding with plantar fasciitis pain, not by itself or separate, can be a plantar fibroma, which is a typical nodule and by definition would be a fibrous tumor, but a benign fibrous tumor of the plantar fascia, typically in this area, typically about 1 centimeter in size, but I've seen them nearly the entire fascia. I've seen them in 10 or 20 multiples, but most commonly a nodule right in this particular area. And it may be painful, and someone may come in thinking they have plantar fasciitis when it's simply a firm nodule. Now also, if there is a plantar fibroma here, or here, multiple, that is going to tighten the fascia even more, making the fascia tighter and making fasciitis even more likely. So that is something to consider, and then discussing treatment modalities such as surgical excision of the fibroma, or what I've gone to almost exclusively is a compound verapamil to shrink the fibroma, and that's a whole nother topic. However, be aware, always palpate the entire fascia and look for any little nodules that are there. And here from the bottom you would see the nodule outside on the plantar aspect of the plantar fascia here, usually not extending up in this direction, or if I've removed them surgically, it's usually just here in and around the plantar fascia, not extending into the muscle belly deeper. One more aspect to look for on x-ray within the anatomy of the subtalar joint through here is a subtalar coalition. If there's any at-birth union between the subtalar joint, which might be seen by talar beaking up here, or abnormal surfaces through here, which would cause the foot to overpronate typically, and that may be a source of your rear foot pathology. It's just something else to discuss and address in the overall scheme of the biomechanics of plantar fasciitis. One more look at the anatomy, and in understanding the anatomy from this view and this view is asking the patient and finding out, and of course then compressing yourself, where is the pain? Is it here? Here, classic, almost always in these areas. If there is pain up higher, they may have a spring ligament injury, and that may be mistaken for plantar fasciitis. They may have first metatarsal cuneiform pain here, or the supporting ligament here. Very similar in area, very similar in the pathology as part of excess pronation, but look closely, palpate closely, and palpate around the area in all of these spaces, not just at the fascia insertion. And no one said you can't have multiple issues, as they all are aggravated by excess pronation. Also, another anatomy tip, this is the classic spot of initial plantar fasciitis, but loosening this, doing all the proper treatments, this tight band here may be loosened, and then the pain may move centrally and eventually laterally as these areas loosen across, moving lateral, with the last being the lateral band then to loosen up. Also, keep in mind when you're asking the patient to roll a can, a PVC pipe, a rolling pin, a bottle, whatever it may be, on the bottom of the foot, make sure they're not just rolling here, but the entire length of the fascia through here, breaking up all of these adhesions. Here is another look at the plantar fascia or plantar fasciitis, inflammation in this area. Common questions are, do I have a heel spur? Is it the spur that hurts? And the spur is pointing in this direction here. You're not walking on a vertical spur, so the spur is fairly irrelevant. It just, think of it as a traction spur pulling this direction, and an inflammation of the fascia here, and in some cases fasciitis throughout the fascia further distal. However, localized inflammation here associated around the spur, sure, or within the fascia, or without a spur at all. Just another look at the fascia as a support structure and seeing it extending out through the entire bottom of the foot. When we get to a can rolling type exercise, we don't want the patients just rolling here, but the entire length up to just proximal to the metatarsal heads, as this big structure will need to be massaged and to help break up scar tissue and adhesions for more mobility of the plantar fascia.